I want to tell you about a patient of mine. Her name is Catherine. Catherine is 70 years old, and she came to see me about 8 months ago for what she thought would be a routine appointment. She was not in pain. She was not short of breath. She had no symptoms that worried her. She walked 3 miles every morning. She ate well. She took her blood pressure medication without fail. She was the kind of patient that makes a doctor feel like they are looking at someone who is doing everything right. Her blood pressure that morning was 126/78. Her cholesterol numbers were well managed on a low dose statin. Total cholesterol 184, LDL 96, HDL 54, triglycerides 128. Good numbers. Numbers that most doctors would look at and feel reassured. And Catherine herself was reassured. She had been reassured for years by numbers like these, by a doctor who told her her heart was fine.
Her risk was managed. She was doing everything right. But I had been her doctor for 3 years, and I knew something about Catherine that her numbers alone did not tell me. Her father had died of a heart attack at 61. Her older brother had needed a coronary stent at 64. And Catherine, despite her good numbers, despite her walking, despite her medication, had never had her arteries actually looked at from the inside. And I said, Catherine, I want to order a test for you. It is called a coronary artery calcium scan, and I want to see what your arteries actually look like. She looked at me and said, but my numbers are good. And I said, your numbers are excellent, and I still want to see what your arteries look like. Because numbers on a blood test tell us about the chemistry of your blood. They do not show us what has been happening inside your arterial walls for the past 70 years. And Catherine agreed. And 2 weeks later, she came back with the results. And I want to tell you what those results showed and why what happened in that appointment changed everything about how Catherine understood her own heart. I am Dr. Daniel Chen, and today I want to explain what a coronary artery calcium scan is, what it actually shows, why it is one of the most important and most underused tests in cardiovascular medicine after 65, and what Catherine's results taught both of us about the difference between looking good on paper and actually knowing what is happening inside your arteries. So let me start with what the test is and how it works, because most people have never heard of it, even though it has been available for over 20 years and has some of the most compelling evidence of any cardiovascular test in medicine. A coronary artery calcium scan is a special type of CT scan of the heart that takes approximately 10 to 15 minutes, involves no injections, no contrast dye, no preparation, beyond avoiding caffeine for a few hours beforehand, and no recovery time. You come in, you lie in a scanner bed. The scanner takes a series of very fast, very detailed images of your coronary arteries, the 3 main arteries that supply blood to the heart muscle. And the images are analyzed by a radiologist who measures the amount of calcium deposited in the walls of those arteries. And here is why calcium matters. When I say calcium in the arteries, I do not mean the calcium you get from milk or from supplements. The calcium detected in a coronary artery calcium scan is a marker of something specific that has been happening inside the arterial wall over many years. As I described in my video on arterial health, the process of atherosclerosis, the buildup of plaque inside the arterial wall, goes through several stages. In the early stages, the plaque is soft, made up of lipid-rich material, foam cells, and inflammatory cells. At this stage, the plaque is dangerous because it is unstable, prone to rupture, but it is invisible
on most imaging, including standard chest x-rays and even standard CT scans. But as the plaque matures over years and decades, calcium begins to deposit within the plaque material. This calcification is the body's attempt to stabilize and wall off the growing plaque. And the presence of calcium in the coronary arteries is a direct marker of the presence and extent of atherosclerosis in those arteries. The amount of calcium is expressed as a number called the Agatston score, or simply the calcium score. A score of 0 means no detectable calcium in the coronary arteries and is associated with a very low risk of a cardiovascular event in the near term. A score of 1 to 100 means mild calcification, indicating early or mild atherosclerosis. A score of 101 to 400 means moderate calcification, and a score above 400 means extensive calcification and significantly elevated cardiovascular risk. Now, here's why this test is so profoundly important for adults over 65 and why it tells you something that no blood tests can tell you. Your blood tests, including your cholesterol numbers, your inflammatory markers, your blood pressure readings, tell you about the chemical environment of your blood right now. They give you a snapshot of how various risk factors are currently controlled or not controlled, but they cannot tell you what has already happened inside your arterial walls. Over the past 40 or 50 years, before you started your medications, before you changed your diet, before you started exercising, the coronary calcium scan can tell you that, because the calcium in your arterial walls is the physical record of everything that has happened inside those arteries. Over your lifetime, it is the scar tissue of decades of plaque development. And it does not lie. It does not respond to how good your last 3 months of cholesterol readings looked. It is the accumulated evidence of a lifetime, written into the walls of your arteries in calcium that a scanner can see. Now, let me tell you what Catherine's score was when she came back with her results. She sat down in my office and she put the report on the desk between us. Her calcium score was 287, which places her in the moderate to high category for her age and gender, specifically at the 82nd percentile for women her age, meaning her calcium score was higher than 82% of women of her age in the population studied. Catherine looked at that number for a long moment, and then she looked at me and she said, "But my blood pressure is controlled. My cholesterol is controlled. I walk every day. I eat well. How can this be?"
And I want to tell you what I told Catherine, because it is one of the most important conversations I have ever had with a patient. I told her, "Catherine, everything you have been doing for the past several years has been the right thing to do. It has been protecting your arteries from further damage from the day you started. But those arteries started accumulating this calcium long before you were on a statin, long before your blood pressure was controlled, long before you started walking 3 miles every morning. What we are looking at is the record of what was happening inside your arteries over decades. And that record does not change, because your last blood test looked good. What it tells us is that the risk factors you were managing had been at work inside those arteries for a long time, and that we need to manage them more aggressively than a person with a calcium score of 0 would need. Not because you have done anything wrong, but because of the reality of what has already accumulated inside those arterial walls. Catherine asked me, "Is this dangerous right now?" And I told her honestly, a calcium score of 287 does not mean you are about to have a heart attack. The calcium itself represents the older, more stable plaques in your arteries. What we cannot see with this scan are the newer, softer, more unstable plaques that pose the most immediate risk. But what the score tells us is that your arteries have a significant atherosclerotic burden, and that the likelihood of more plaques being present, including unstable ones, is meaningfully higher than it would be in someone with a score of 0. And it tells us that we need to be more aggressive in managing every risk factor we can influence to reduce the chances of one of those plaques becoming a problem. Now, let me tell you what the coronary calcium score actually changes in terms of clinical management, because this is where the real value of the test becomes clear. For Catherine, her calcium score changed 3 things in her care. The first was her statin therapy. Before the calcium score, Catherine was on a low-dose statin, rosuvastatin 5 milligrams, which was adequately controlling her LDL to the target her previous doctor had set. But the calcium score changed the target. Research has shown, specifically from the MESA study, a large landmark study that followed over 6,000 adults for many years, that a calcium score above 100 is associated with a significantly elevated cardiovascular risk that warrants more aggressive LDL lowering than a person with a lower score would require. For Catherine, with a score of 287, I discussed with her increasing her statin dose to target an LDL below 70, rather than her current below 100 target, because the evidence suggests that for people with significant coronary calcium burden, lower LDL targets produce greater reductions in cardiovascular events than standard targets do. The second change was aspirin therapy. The role of low-dose aspirin in cardiovascular prevention has been the subject of significant revision in recent years for primary prevention in people without established heart disease. The guidelines have moved away from routine aspirin for most older adults because the bleeding risk often outweighs the benefit for people without established cardiovascular disease. But for people with a high calcium score, specifically scores above 100, research has suggested that the risk-benefit calculation may be more favorable for carefully selected individuals. I discussed this with Catherine, and with her complete clinical picture, including her family history and her calcium score, we had an explicit conversation about whether low-dose aspirin was appropriate for her, based on her individual risk, rather than applying a generic recommendation. The third change was the intensity of monitoring and lifestyle reinforcement for Catherine. Knowing what was inside her arteries changed how she thought about every lifestyle recommendation I had ever given her. She told me, when you just say, exercise is good for the heart, it sounds like general advice you give to everyone. But when you can see what is inside your arteries, you suddenly understand why it matters personally, for you specifically, not for everyone, for you. And I think that is one of the most underappreciated values of the calcium scan. It transforms abstract risk into something real that a person can see on a piece of paper and respond to with genuine urgency rather than vague intention. Catherine left my office with a clearer picture of her own heart than she had ever had in 70 years of living. She knew what was there, she understood what it meant, and she knew exactly what she was going to do about it. Now let me explain who should consider getting a coronary calcium scan, because not everyone over 65 needs one, and the decision should be made in conversation with a doctor. But the people who are most likely to benefit from knowing their score are those in the intermediate cardiovascular risk category. People who are not obviously at very high risk because they have already had a heart attack or stroke. Those people already know their risk is high and are already being managed aggressively, and not obviously at very low risk because they are young, have no risk factors, and no family history. The people in between, the 60-year-old woman with modestly elevated cholesterol and blood pressure, but no symptoms. The 68-year-old man whose father had a heart attack at 65, but whose own numbers look reasonably controlled. The 72-year-old woman, like Catherine, whose numbers are good on paper, but whose family history and whose age make you wonder what might be happening inside those arterial walls that the numbers are not revealing. For these individuals, a calcium score can be genuinely transformative in how their risk is understood and managed. A score of 0 in an intermediate risk individual provides remarkable reassurance. Research has shown that a calcium score of 0 in an adult with intermediate cardiovascular risk is associated with such a low, short to medium-term risk of a cardiac event that it may justify deferring statin therapy if the person prefers not to take it until their score is reassessed. A score above 100 or at a high percentile for age provides a clear signal that more aggressive management is warranted and justifies both the doctor and the patient taking a more proactive and more intensive approach to risk factor management than the basic numbers alone might have suggested. The test cost approximately $100 to $400 in the United States, is not always covered by insurance, though coverage is increasing as the evidence for its value continues to accumulate. It is widely available at most hospitals and cardiac imaging centers, and it involves a radiation dose that is low, approximately equivalent to the radiation exposure of a mammogram or a few months of natural background radiation for most adults over 65 in the intermediate risk category. The information it provides about what is actually inside their arterial walls is worth far more than the cost or the minimal inconvenience of the scan itself. Now, let me also tell you what I told Catherine after we went through everything I have described about what her score meant and what we were going to do about it. Because I want to end with her words, not mine. She looked at me and she said, "I wish someone had ordered this test 5 years ago." And I said, "Catherine, the scan you had today shows what was there 5 years ago and 10 years ago and 15 years ago. What it gives us now is the knowledge to make the next 20 years different from what the previous 20 put inside those arteries. And that is not a small thing. That is everything." She smiled and she said, "Then let's get to work. Let me bring everything together now. The coronary artery calcium scan is a non-invasive, low-radiation CT scan that takes 10 to 15 minutes and measures the amount of calcium deposited in the walls of the 3 main coronary arteries. The calcium score, expressed as an Agatston score, is a direct marker of the presence and extent of atherosclerosis in those arteries, accumulated over a lifetime. It tells you something that no blood test can tell you: what has already happened inside your arterial walls over the preceding decades for adults over 65 in the intermediate cardiovascular risk category with any of the following: a family history of early heart disease, modestly elevated cholesterol or blood pressure controlled with medication but present for years, or a personal history of diabetes or smoking even decades ago. A calcium score can transform how their risk is understood, how their treatment is targeted, and how personally and urgently
They engage with every lifestyle recommendation their doctor has ever given them. Catherine's score was 287. Her numbers looked good, but her arteries told a different story. And knowing that story changed everything about how we manage her heart health going forward. If you are over 65 and you have any of the risk factors I have described, and you have never had a coronary artery calcium scan, I want you to ask your doctor about it at your next appointment. You can say, I would like to discuss whether a coronary artery calcium scan would be appropriate for me, given my age and my risk factors. That is a completely reasonable and clinically informed request, and a good cardiologist or a good internist will take it seriously. I am Dr. Daniel Chen. If this video gave you a picture of something happening inside arteries that no blood test has ever shown you, please share it with someone over 65 who thinks their heart is fine because their last blood test looked good, and who has never been told about the test that actually shows what is inside their arterial walls. Subscribe to this channel for weekly videos made with genuine care for older adults who deserve real information about their own health. And leave me a comment below. Tell me whether you have ever had a coronary artery calcium scan and what your score was.
If you have, I read every single comment, and I genuinely look forward to hearing from you. Take care of your heart, not just the numbers that represent it, but the arteries themselves, because now you know how to see them.